I'm Dr. Bongomin Felix, and I will be giving a talk on flucytosine, which is one of the available systemic antifungal agent. So we shall look at the structure and mechanism of action of flucytosine, and we also want to be aware of the pharmacokinetics and pharmacodynamics of flucytosine. We want to see the different formulations of flucytosine available for clinical use, and we want to know the different clinical indication for the use of flucytosine, the indication and the dose for each indication. We want to know the adverse events that are related to the use of flucytosine, and we shall also look at resistance and resistant mechanism that is often seen in clinical practice. Flucytosine is one of the synthetic fluorinated analog of cytosine, and cytosine is a pyrimidine, which is actually a base that forms essential component of DNA, RNA, and nucleotides. And initially it was made for the purpose of treating leukemias and other forms of cancers, but it gained a clinical use for treating of fungal infections rather than cancer. And it is the only antimetabolite systemic antifungal in clinical use. Flucytosine was one of the earliest antifungal agents to be brought into clinical practice, as you can see in the pipeline of discovery of antifungal. It is one of the essential antifungal agents that is listed on the World Health Organization list, essential medicine list, but it is not available in many parts of the developing world. Then how does flucytosine work? Well, it works in a more complex mechanism, but the first step in its action is that it has to be brought from the extracellular, outside the fungal cell, to the inside, into the cytoplasm by the help of an enzyme that is called cytosine permease that allows flucytosine to move from outside of the fungal cell inside to inside the cytoplasm of the fungus. Then what happens is that flucytosine is then converted into another form of a pyrimidine that is called uracil. So with the help of an enzyme that is called cytosine deaminase that removes parts of the amide in flucytosine and converts it into 5-fluorouracil. Then 5-fluorouracil is converted into another compound, intermediate compounds, that is called 5-fluorouridine monophosphate, that will be with the help of an enzyme that is called uracil phosphoribosyl transferase. Then from there, the intermediates of fluorouracil then has two fates. One goes into the inhibition of RNA, thus inhibition of protein synthesis. Then the other one goes to inhibit a critical enzyme that is used for DNA synthesis that we call thymidylate synthase. So if thymidylate synthase is blocked, then DNA cannot replicate, and that is how it inhibits DNA synthesis. So you can see that flucytosine, in its antimetabolite activity, it acts at two main levels, but inhibiting both DNA, RNA, and then protein synthesis. We have to look at the spectrum of activity. Unlike the other systemic antifungals, like the triazoles, flucytosine has a very narrow spectrum of activity, and that is largely to Cryptococcus and Candida species, and among the molds, it is only restricted to few agents that cause a subcutaneous disease called chromoblastomycosis. Then in this table, we have tried to compare the spectrum of activity of flucytosine with the other triazoles. And you can see clearly that flucytosine has a very restricted spectrum of activity, mainly to the Candida species, but significantly also to Cryptococcus species, and that is where it has gained most of its clinical use in. But we also have activity against agents of chromoblastomycosis. Unlike the other, triazole, which has a wider spectrum of activity, including Aspergillus, dimorphic fungi, and the other molds. So looking at resistance to flucytosine, resistance can be primary resistance or secondary resistance, or what we call intrinsic resistance and extrinsic resistance. Intrinsic resistance to flucytosine is fairly common, between 2 to 10% of Candida isolates, and in fungi that do not have the enzyme cytosine permease, because if the fungus doesn't have cytosine permease, then flucytosine cannot move from outside of the fungal cell to inside, and therefore it cannot exert any effect on that on the fungus. Then acquired resistance is very common, especially if you use flucytosine as a single agent, and so for that flucytosine is always used in combination with other antifungal agents like amphotericin B to avoid secondary resistance. A very early study looked at the prevalence of acquired resistance to flucytosine following monotherapy, and it showed that up to 23% of Candida isolates in the US actually acquired resistance to flucytosine if it is used as a monotherapy. And that was fairly also common in other parts of the world, with an overall prevalence of acquired resistance being about 9%. Then how does this resistance come in? One mechanism is that we have fungi that do not have cytosine permease that is responsible for moving flucytosine from outside of the fungal cell into the cytoplasm. And so if flucytosine cannot be moved inside the cytoplasm of the fungal cell, then there's no way it will inhibit the DNA or RNA synthesis. Then the fungus sometimes they become very clever by producing more of the pyrimidines, because we know we have 3 pyrimidines. So they can produce more and outweigh what the drug we are giving is inhibiting, and so they will still carry on with their metabolic activities. Then the other possible mechanism of resistance is that we have defective uridine monophosphate pyrophosphorylase, which is an enzyme that is used to convert 5-fluuracil into the other moieties that can then inhibit RNA and DNA synthesis. Then the other fungi that do not have the activity of cytosine deaminase, which is supposed to convert 5-flucytosine into 5-fluorouracil. And so because of that, the activity of flucytosine will be limited. Flucytosine can be used for oral administration or intravenous administration. And it can either be in tablet form or in capsule form, and it comes in 2 strengths, either 250 milligrams or 500 milligrams. And the one for IV use comes in a 250 ml infusion bottle with a strength of 10 milligrams per ml. And infusion should be between 20 to 40 minutes, because we have adverse events that can be related, that can be infusion related, but that is very rare. Now, what do we use flucytosine for in daily clinical practice? One of the most important clinical indications for flucytosine is actually cryptococcus meningitis, where it is used in combination with amphotericin B, mainly with amphotericin B to give the highest impact. Then, where the echinocandins cannot be used, we use in combination with amphotericin B, flucytosine in combination with amphotericin B for treating severe systemic candidiasis. Then we shall understand from the pharmacokinetics that flucytosine is mainly excreted unchanged in urine, and because of that, we use it for treating urogenital candidiasis, but usually as a short course and monotherapy, not in combination with any other antifungal agent. And we also use this for treating cases of chromoblastomycosis, but this is an off-label indication. What is the advantage of combining flucytosine with amphotericin B when we are treating fungal infection? One is that amphotericin B enhances the rate of entry of flucytosine into the fungal cell. And because of that, then you'll get a higher bioavailability within the fungal cell, and you achieve higher rate of DNA and RNA synthesis. And two is that when you use the two in combination, the likelihood of reducing amphotericin B or flucytosine B or flucytosine adverse events will be achieved, because you will use lower doses of both agents and to achieve a synergistic clinical effect. And that a combination of the two leads to a rapid conversion of culture, of Cryptococcus culture. When you combine the two, we also achieve reduced duration of therapy without compromising efficacy of the agents. And that the likelihood of resistance is decreased by using two agents of different mechanism of action. And studies have already shown that a combination of amphotericin B and flucytosine is associated with improved survival compared to flucytosine or amphotericin B monotherapy. Stressing on the last point, a randomized clinical trial was published some few years ago where 299 patients from Vietnam were randomized to either amphotericin B monotherapy or amphotericin B with flucytosine or amphotericin B and fluconazole. It was clearly demonstrated that a 2-week survival and 10-week survival was much higher in patients who received both amphotericin B and flucytosine compared to patients who were only on amphotericin B, with only 15% mortality at 2 weeks for the patients who were on amphotericin B combined with flucytosine, compared to 30% mortality in patients who were only on amphotericin B at 2 weeks. And there was no survival benefit that was associated with amphotericin B combined with fluconazole compared to the other agents. And that actually patients who had a combination of amphotericin B with flucytosine had a rapid conversion of their culture results. Another randomized clinical trial was done in Malawi, which is one of the resource-limited settings in sub-Saharan Africa. And they clearly demonstrated that fluconazole combined with flucytosine was superior to fluconazole monotherapy. So in resource-limited settings where amphotericin B, the good form, liposomal amphotericin B, is not available, a use of fluconazole in combination with flucytosine can also be encouraged in such settings. So we want to look at the dose of flucytosine for the different indications. For adults with candidiasis, systemic candidiasis, or cryptococcal infection, flucytosine is given at the dose of 50 to 150 milligrams per kg per dose, divided into 4 doses, usually 6 hours apart. But the usual dose for flucytosine is usually 100 milligrams per kilogram body weight per day in 4 divided doses, usually given 6 hours apart. Then in children who are beyond the neonatal period, we also give almost at the same dose as for adults. That is 100 milligrams per kg per day in 4 divided doses. But for neonates, we usually give at a relatively higher dose compared to the adult dose because of their high surface area to volume ratio. But doses should always be adjusted depending on the renal function. we want to look at the pharmacokinetics of flucytosine. So after oral administration of flucytosine, about 75 to 90% of flucytosine gets absorbed into the bloodstream, and it is well distributed into many parts of the body, but importantly into the CSF, and that is where it gains a good indication for treating cerebral infection like in cryptococcal meningitis. But it can also go into different body compartments, and the protein binding is only about 2 to 4%. That means most of the active components of flucytosine remains within the blood circulation. And the half-life is usually very short in normal individuals, between 3 to 8 hours. And that is why flucytosine is, the dosing is 6 hourly because of the half-life. But the half-life is higher in patients who are anuric or in patients with end-stage kidney disease, because it is exclusively excreted in urine, and so it tends to accumulate into the bloodstream if it is not excreted. And the peak plasma level is achieved 2 to 6 hours after oral administration, with the peak concentration after 2 hours of administration being 70 to 80 milligrams per liter, and a trough concentration of about 30 to 40 milligrams per liter. And metabolism is minimally hepatic, unlike the triazo class of antifungals. And excretion, as I've already talked about it earlier on, it is mainly renally. Looking at flucytosine dosing in renal impairment, this table just demonstrates that the individual dosage is usually the same, 25 milligrams per kg per dose. That totals up to 100 milligrams per kg per day. But the dosing interval is the one that usually varies depending on the creatinine clearance level. But the lower the creatinine level, the longer the dosage interval. Then, how about the use of flucytosine in patients who are pregnant or who are breastfeeding? In animal studies, I've already demonstrated that that flucytosine is teratogenic, and that goes back to its mechanism of action, that it interferes with DNA and RNA synthesis. So theoretically, we expect it to be teratogenic, but clinical studies have not demonstrated the teratogenic capabilities of flucytosine, and so it mainly depends on your clinical judgment. If the risk of teratogenicity outweighs the benefit of survival following a potentially fatal fungal disease, then you should not use. But if you see that the benefit clearly outweighs the risk, then it can be justified in some clinical cases. Then breastfeeding, the excretion of flucytosine in breast milk is not known. So the manufacturers advises that it should be avoided in patients who are breastfeeding. The use of flucytosine in people who are elderly or patients who have blood disorders, we advise that you monitor for major organ functions like the liver, kidneys, and you do complete blood count for these patients at least every week, and that their drug concentration should routinely be monitored. Then, how do you monitor flucytosine drug levels, and in whom should actually this drug be monitored? The rationale is that flucytosine has a very narrow therapeutic index, and therapeutic drug monitoring prevents serious dose-limiting toxicities, because if the therapeutic drug level is between 40 to 100 or a little tight, but levels that are beyond 100 milligrams per liter is most likely going to cause serious drug-induced liver injuries. then levels between 100 and 125 milligrams per liter will definitely put a patient at the risk of bone marrow suppression. Then on the other side, if we keep to very low levels, less than 25 milligrams per liter, then we increase the likelihood of a patient getting resistance to this agent. And there are various methods that can be used for detecting serum levels of flucytosine. The most common and cheap method is the bioassay, but other methods also exist, like the high pressure liquid chromatography, the gas liquid chromatography, mass spectrometry, and other methods. Then the target plasma concentration for optimum response to flucytosine is usually between 25 to 50 milligrams per liter, and that is for pre-dose blood sample, and a little higher for patients who are non-neonates. We usually tend to want the peak concentration to be between 70 to 80 milligrams per liter, and the trough should be maintained between 30 to 40. And that means you want to avoid toxicities, and it shouldn't go beyond that, and at the same time you want to avoid resistance from emerging. A previous study had been published to describe clinical experience from the use of flucytosine in a large hospital in the UK, and it showed that actually about 40% of the patients had low levels of flucytosine, and about 40% also had high levels of flucytosine, and only about 20% had their flucytosine levels within the therapeutic range. And that tells you the implication of routine monitoring of flucytosine blood levels in detecting who is at risk of adverse events and who is at risk of acquiring resistance to this agent. Then, what are the side effects that are usually seen in patients who are getting flucytosine? The most common side effects are gastrointestinal side effects like nausea, vomiting, diarrhea, and abdominal pain. And this is actually not specific to flucytosine, because other antifungal agents and other antibiotics out there also still give this kind of side effects. But the most serious side effects of flucytosine, though they are not so common, are liver injuries, or mainly hepatitis and hepatic necrosis, and that is usually associated with very high levels of flucytosine, and bone marrow suppression, because it goes back to the mechanism of action of flucytosine. So it can cause thrombocytopenia and leukopenia and aplastic anemia. But the good news is that these side effects are reversible so long as the drug is stopped or the dose reduced appropriately. And other side effects include dizziness, drowsiness, photosensitivity, and other side effects which are not really specific to flucytosine. Then cautions, as we have already talked about, is that patients who have renal impairment, you have to adjust the dose of flucytosine depending on their creatinine clearance. And patients who already have bone marrow suppression, because we know one of the adverse events of associated with the use of flucytosine is also bone marrow suppression. So you don't want to exacerbate the already pre-existing bone marrow suppression. And patients who have blood dyscrasias should also be monitored, because we also know one of the adverse events associated with flucytosine is thrombocytopenia, leukopenia, and others. So we should always monitor flucytosine level and make sure and maintain the blood levels to less than 100 but above 25 to cater for either side. Then we monitor hematological, renal, and hepatic function at least every week. Then toxicities are more likely to occur if serum levels are more than 100, and of course resistance if serum level is less than 25. And effects are usually reversible, as I've already said earlier on, if treatment is discontinued or the dose is reduced. When are you not supposed to give a patient flucytosine? If a patient had previously had a dose of flucytosine and experienced hypersensitivity, then this is the type of patient that you would not want again to re-challenge with flucytosine, because we know hypersensitivity gets worse with, sometimes it can get worse with a re-challenge. Then drug interactions. We have few drug interactions with flucytosine compared to the other antifungals. So I've already talked about the synergy between amphotericin B and flucytosine, and that there is decreased renal excretion, especially because amphotericin B can cause renal injury. And so because of that, the excretion of flucytosine, which is actually exclusively excreted renally, will be decreased. And because of that, you are likely to increase toxicity. Then other nephrotoxic drugs, not only amphotericin B, but other drugs, maybe anti-cancer like paclitaxel and other drugs, they also decrease elimination of flucytosine, and that still increases toxicities. And other drugs like cytarabine. In fact, flucytosine is an intermediate metabolite of cytarabine. So the two will competitively inhibit each other because they have similar structure. And that will reduce plasma concentration. And so you should always avoid co-administration of these agents. And other myelosuppressive drugs like zidovudine, which is anti-HIV drug, and ganciclovir, which is used for treating herpes simplex infection. Those will increase myelosuppressive effects of flucytosine. So in summary, flucytosine is a synthetic systemic antifungal with narrow spectrum of antifungal activity, but in combination with amphotericin B, it is the most effective regimen for cryptococcus meningitis, which is associated with improved survival and culture conversion. And it has a very narrow therapeutic index, and that means we should always monitor drug levels for patients who are on flucytosine. And myelosuppression and liver toxicities are the most serious adverse events that are associated with flucytosine therapy, and drugs should be discontinued or the drug reduced appropriately in case you see these adverse events in this patient. Thank you. Okay. Now we want to look at the clinical indications for flucytosine. When do we use flucytosine? Now we have quite a number of indications for flucytosine. One and the most important clinical indication for use of flucytosine is in the treatment of cryptococcus meningitis, where we use flucytosine in combination with amphotericin B for this disease. The other indication is the treatment of severe systemic candidiasis, also in combination with amphotericin B. But usually, this can only come in if the other agents for treating systemic candidiasis, like the echinocandins, cannot be used. Then also in the treatment of urogenital candidiasis, we use flucytosine as a monotherapy, as a single agent for treating this disease. This is because flucytosine is largely excreted and changed in urine, and that makes it highly bioavailable for treating candida infection of the urinary tract. Then the other indication for flucytosine is for the treatment of a subcutaneous disease that is called chromoblastomycosis. But this is an off-label indication. Then, as we have seen that in the treatment of cryptococcus meningitis, you need to combine amphotericin B with flucytosine. Then what are the advantages associated with a combination of flucytosine with amphotericin B? One of those advantages is that amphotericin B enhances entry of flucytosine into the fungus cell, and that the combination of amphotericin B and flucytosine has already been shown in randomized clinical trials that it rapidly enhances the culture conversion of patients who have cryptococcal meningitis. And the other advantage is that a combination of the two drugs gives reduced. When the two drugs are combined, we give the treatment for a shorter duration of time compared to if the drugs were if amphotericin B was given alone for the treatment of cryptococcal meningitis. And the two drugs, amphotericin B and flucytosine, have different mechanisms of action, and because of that, it reduces the likelihood of acquired resistance, which is very common in flucytosine monotherapy. And last but not least is that the combination of amphotericin B and flucytosine has been shown in a large randomized clinical trials that it improves both 2-week and 10 weeks survival.
Okay. Yeah. Very good. All right, lovely. Thank you very much.